Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the anatomy of the rectus sheath. What is rectus sheath? The rectus sheath is an aponeurotic sheath around the rectus abdominis muscle. So, if you define what is rectus sheath, this is an aponeurotic sheath or covering over the rectus abdominis muscle. Okay, so you got the definition of the rectus sheath. This is an aponeurotic or connective tissue sheath around the rectus abdominis muscle. Location, where it is located? It is located in the middle of the anterior abdominal wall, anterior abdominal wall, abdominal wall. Okay, we got the location and the definition of the rectus sheath. Now we'll go how it is formed, who contribute in the formation of the rectus sheath. Rectus sheath is formed by the aponeurosis of external oblique, aponeurosis of internal oblique, aponeurosis of transversus abdominis muscle. These all are anterolateral muscles of the abdomen. They all contribute in the formation of the rectus sheath, plus the fascia transversalis, and posteriorly certainly will get the parietal peritoneum after the fascia transversalis. So it is formed by the aponeurosis of the external oblique, internal oblique, transversus abdominis, these are the main contributor. It also gets contribution by the fascia transversalis. So here we get, this is the external oblique, this is the internal oblique, IO means internal oblique. Then this is the transversus abdominis, and they had the aponeurosis here. Those aponeurosis contribute in the formation of the sheath around the rectus abdominis muscle. So this is rectus abdominis muscle, and this is covered by aponeurotic sheath. That aponeurosis is coming from the external oblique, internal oblique, transversus abdominis. Okay, so we got the contributor for the formation of the rectus sheath. The rectus sheath, if you go to the characteristic of rectus sheath, okay, rectus sheath has features. It has features depending on the location. Features on location. Okay, the rectus sheath above the costal margin. So this is the costal margin. Costal margin. So the muscle, rectus abdominis muscle, it is inserting to the costal cartilages of 5, 6, 7. Okay, so we got the rectus sheath above the costal margin like this. Rectus sheath between the costal margin and the arcuate line. This is the arcuate line here. Arcuate line will get this type of feature. Okay. Below the arcuate line, this is the arcuate line. This is the symphysis pubis. Okay. So this will give the feature like that. We'll go through that part. Okay. So how about the rectus sheath? What is formed? How it is formed anteriorly? So aponeurosis of external oblique is present throughout the rectus sheath. Aponeurosis of the external oblique, just say external oblique, EO, external oblique, is continuous over the entire rectus sheath. That means what? The anterior layer of the rectus sheath that is contributed by that is formed by the aponeurosis of external oblique is present here above the costal margin. From the costal margin to the arcuate line. This is the arcuate line. Arcuate line. Okay. So, and also the rectus sheath over rectus sheath covering anterior covering below the arcuate line will get the aponeurosis of external oblique. So aponeurosis of external oblique is present here throughout the entire rectus sheath up to the symphysis pubis. So aponeurosis of external oblique is present everywhere. Okay, in all three regions. We have three regions. This is above costal margin, above costal margin. This is okay below costal margin, to the arcuate line. Arcuate line is a concave line that is present between the umbilicus and symphysis pubis. So this is arcuate line. That is an arcuate concave line between the umbilicus and the symphysis pubis. So this is the umbilicus. This is the symphysis pubis. Symphysis pubis. Okay, we got that. So this feature is present below the costal margin up to the arcuate line. This feature is present below the arcuate line. So that is below the arcuate line. Okay, we got the three type of features and contributing aponeurosis here, there, and here. Okay, so if you go to the rectus sheath above the costal margin, what the contributor? So above the costal margin, okay, the anterior wall or lamina of the rectus sheath is formed by the aponeurosis of external oblique, aponeurosis of external external oblique. Okay. And above the costal margin, the posterior layer of the rectus sheath is deficient. The posterior layer or wall of the rectus sheath is deficient. So the rectus abdominis muscle just insert to the costal cartilage number 7, 6, 5. So these are costal cartilages. Okay, they are the costal cartilages. Costal cartilages. So like this, 7, 6, 5 costal cartilages. The rectus abdominis is on the costal cartilages, and the anterior layer of the rectus sheath will be blended with the bone like the xiphoid process. This is the xiphoid process. Xiphoid process. Okay, we got the rectus sheath above the costal margin. Here, rectus sheath above the costal margin. Okay, so we got that. Now we have to know the rectus sheath formation between the costal margin and the arcuate line. Okay, then between the costal margin and the arcuate line. Okay, again, anterior layer is formed by the aponeurosis of external oblique. Anterior layer is formed by aponeurosis of external oblique plus we'll go to the internal oblique here. This internal oblique will be split into two lamina. Okay, and anterior lamina of the internal oblique. Okay, we got that. So this is external oblique, this is internal oblique. Internal oblique aponeurosis will be split into two. Anterior lamina will go anterior to the rectus abdominis muscle. Posterior lamina will go posterior to the rectus abdominis muscle. So how the anterior wall of the rectus sheath is formed by the aponeurosis of external oblique and anterior lamina of the internal oblique. We got that. Formation of anterior wall of the rectus sheath between the costal margin and the arcuate line. This is the formation. Okay. Then we'll go to the rectus sheath formation below the costal margin. Rectus sheath formation below the costal margin. Before going there, how about the posterior layer of the rectus sheath formation between the costal margin and the arcuate line? Okay, again we can write between the costal margin and the arcuate line. Okay, the posterior layer is formed by the posterior lamina of the internal oblique and transverse abdominis muscle. By the posterior lamina of the internal oblique and the fascia transversalis. Okay, it is supported by the parietal peritoneum. Here is the falciform ligament. This green is the fascia transversalis. Fascia transversalis. Okay, this is the falciform ligament. Falciform ligament that carries the ligamentum teres hepatis, the obliterated left umbilical vein. Okay, so posterior wall is formed by the posterior lamina of the internal oblique and the aponeurosis of transversus abdominis. We must add here posterior lamina of the internal oblique and the aponeurosis of transversus abdominis, aponeurosis of transversus abdominis and the fascia transversalis. Okay, so again let us summarize. The rectus sheath between the costal margin and the arcuate line. Anterior layer is formed by the aponeurosis of external oblique, anterior lamina of the internal oblique. Posterior wall of the rectus sheath is formed by the posterior lamina of the internal oblique, aponeurosis of transversus abdominis and the fascia transversalis. Okay, we got that. The distribution of the aponeurosis in the contribution of the rectus sheath between the costal margin and the arcuate line. So between the costal margin and the arcuate line, posterior layer is formed by the posterior lamina of the internal oblique, that is this, and the aponeurosis of transversus abdominis and by the fascia transversalis. Okay, we got the rectus sheath between the costal margin and the arcuate line. How about the rectus sheath below the arcuate line? Below the arcuate line. Okay, that is below the arcuate line. Here, aponeurosis of external oblique, internal oblique, transversus abdominis, all aponeurosis will go in front of the rectus abdominis muscle. Okay, all the aponeurosis of the external oblique, internal oblique and transversus abdominis, okay, they pass in front of the rectus abdominis. Okay, then how posterior wall is formed. Okay, this will form the anterior wall. Aponeurosis of external oblique, internal oblique, transversus abdominis. Posterior wall is formed by, okay, pass in front of the rectus abdominis and form anterior wall of rectus sheath. Okay. How about the posterior wall below the arcuate line? Okay. The posterior wall is formed by the posterior formed by the fascia transversalis. Fascia transversalis. Transversalis. Certainly it is supported by the peritoneum. We have in the peritoneum we'll also get the median umbilical fold, median umbilical fold, okay, for the urachus, and medial umbilical fold to medial umbilical fold, okay, for the medial umbilical ligament. Here medial umbilical fold, So we got the formation of the rectus sheath. Now we go the content of the rectus sheath. What are the contents? Okay. Contents. We have two muscles. Okay. Muscles. What are the muscles? We have the rectus abdominis. Rectus abdominis muscle, and we may get pyramidalis. Pyramidalis may be absent around 20% population. Small muscle, okay, just in front of the rectus abdominis, lower part. It looks like a pyramid, so it is pyramidalis, very small muscle. It may be absent. We got the content muscles. How about the vessels? We'll get superior epigastric vessel, that means superior epigastric artery, superior epigastric vein. Superior epigastric artery is a terminal branch of the internal thoracic artery. Superior epigastric vein opens into the internal thoracic vein. And also we'll get inferior epigastric vessel. Suppose inferior epigastric artery is a branch of the external iliac artery. Inferior epigastric vein will open into the external iliac vein. Okay, we got the muscle vessels. Now we'll go to the nerves. We get lower 6 thoracic spinal nerves. Okay. Like what? The ventral lemma of thoracic spinal nerve. Okay. Lower 6 ventral rami of the thoracic spinal nerves. Okay, these are also called thoracoabdominal nerve. These are the T7, T8, T9, T10, T11, Okay, we'll get T11 plus the subcostal nerve. Okay, T7, T8, T9, T10, T11, and T12, that is the subcostal nerve. We may get some contribution from T6 also, especially to supply the upper part of the rectus abdominis muscle. We got the nerve, we got the vessels, nerves. Now we'll go to the functions of the muscles. Okay, we have the muscle. This is the muscle, rectus abdominis muscle. Rectus abdominis muscle. Okay, we have another rectus abdominis muscle here. This is the rectus abdominis muscle. Okay, rectus abdominis muscle, its name is rectus, so its fibers should be straight. So these fibers are taking origin from the pubic crest, from the anterior pubic ligament, from symphysis pubis, and they are inserted to the xiphoid process. This is the xiphoid process, and the costal cartilages, 7 costal cartilage, the 6th costal cartilage, and the 5th costal cartilage. So 7, 6, 5 costal cartilages. Okay. So what is their nerve supply? Again, nerve supply is from T6, T7, T8, T9, T10, T11, and the T12, that is the subcostal nerve. Okay. So this is the rectus abdominis muscle. It is narrower in the lower part, it is expanded in the upper part, expanded. Okay. And we discussed that superior epigastric artery, inferior epigastric artery are content of the rectus sheath. The anastomose usually behind the rectus abdominis muscle at the level of the umbilicus. So if this is the rectus abdominis muscle here, then superior epigastric artery and the inferior epigastric artery, superior and inferior epigastric artery will anastomose here. Here there will be anastomosis around the level of the umbilicus. Okay. So rectus abdominis muscle, we got the nerve supply. What is the action of rectus abdominis muscle? Rectus abdominis muscle is in the center. It compresses the abdominal structures. It helps in the reflexive action of the external oblique, internal oblique transversus abdominis. Rectus abdominis also flexes the vertebral column. Okay, and it acts as a bow, so it prevents excessive flexion, excessive extension. It works in that way. Then we have to give emphasis on the transverse intersections on the rectus abdominis muscle. These are the transverse intersections. Transverse intersections. They are present on the rectus abdominis muscle below the xiphoid process here, around the umbilicus, below the umbilicus, and it is prominent in a masculine person. An anterior layer of the rectus sheath is attached to these transverse intersections. Okay, and idea is that this indicates the segmental development of the rectus abdominis muscle, and it gives strength to the muscle, because by the transverse intersection muscle fiber will be increased, number will be increased, so we'll have more muscle action. Okay, we got the transverse abdominis muscle, we got the rectus abdominis muscle. Okay, so it has transverse intersection. This is the rectus abdominis muscle. We have two rectus abdominis muscle, and we have the another muscle is called, that is the pyramidalis muscle, that is present like a pyramid, that takes origin from the anterior part of the upper aspect of the body of the pubis, and that inserts to the linea alba. What is linea alba? This is called linea alba. Linea alba. This is the connective tissue fold between two rectus abdominis muscle. This is one rectus abdominis muscle. This is another rectus abdominis muscle. This is the linea alba. It is composed of connective tissue. It connects to rectus abdominis muscle, and it is wider in the upper part, narrower in the lower part. This is the linea alba. It extends from the xiphoid process to the symphysis pubis. It is around the umbilicus. Okay, so linea alba is relatively less vascular. So in old time, in case of emergency surgery, surgeon used to take this linea alba to do very emergency surgery. But problem is that it is comparatively less vascular, so there will be more scar tissue formation and delayed healing. There may be wound dehiscence or rupture of the surgical wound. That is possible. Okay, we got the muscle. Okay, now in a thin and lean person on starvation, or in case of multiparity, there may be deviation of there will be extension of the linea alba, this connective tissue. Muscle may be separate out, and we call it divarication of the rectus abdominis muscle. Divarication of rectus abdominis muscle. Okay, so we got that. So now we'll learn some of the applied anatomy or clinical anatomy. Okay. Clinical anatomy we just discussed. This is avascular, not perfectly avascular, not completely avascular. It is relatively avascular. So it may be the route for emergency surgery when diagnosis is very much urgent to do something. So in case of urgency, surgeon use this, but there is possibility of more scar tissue, delayed healing. Okay, in emergency surgery. Okay, there may be wound dehiscence, and in case of starvation or multiparity, there may be divercation. So we got the term. One is divercation, and we also remember if there is any emergency surgery, there may be wound dehiscence. Okay, so that may be possibility there. And also this is the weak point. There may be chance of hernia. Okay, so there may be hernia formation. Okay, there is a possibility formation after surgery. So surgeons don't like to incise on the linea alba. They like to go laterally, so they can retract the nerve. Okay, so we got the content. Again, we'll summarize: muscle, rectus abdominis, pyramidalis. Okay, but we must remember the rectus sheath also contains the lower 6 or 7 intercostal nerve or thoracoabdominal nerve plus the subcostal nerve. So they go along the posterior wall of the rectus sheath. Okay, so that's all about the rectus sheath. If you like my video, please support my channel. Please subscribe me. Please share the information with your friend, and have a nice day. Bye now.